Welcome to our educational video about thrombotic microangiopathy, or TMA, a complex and potentially life-threatening disease affecting the urinary system and beyond. This video will explore the intricacies of TMA, from its causes and mechanisms to diagnosis, treatment, and potential future advancements. TMA isn't caused by a single thing, but rather a variety of factors that trigger the disease process. One key cause is genetic defects impacting the ADMTS13 enzyme, which normally cleaves a protein called von Willebrand factor. When ADMTS13 is deficient or absent, the von Willebrand factor accumulates, leading to abnormal blood clotting. Other causes include infections like E. coli O57CrH7 producing Shiga toxin, certain medications such as calcineurin inhibitors and chemotherapeutic agents, autoimmune diseases like systemic lupus erythematosus, pregnancy-related complications like HELP syndrome, and even hematopoietic stem cell transplantation. In some cases, the cause remains unknown, classified as idiopathic TMA. The heart of TMA lies in its impact on the microvasculature, the tiniest blood vessels throughout the body. When the triggering factor is present, excessive blood clots form in these small vessels. These clots cause damage to the vessel walls, leading to fragmentation of red blood cells as they squeeze through the narrowed and damaged vessels. These fragmented red blood cells are called schistocytes, and they are a hallmark of TMA. This microthrombosis results in organ damage due to decreased blood flow, particularly affecting the kidneys, brain, and heart. The body attempts to compensate for the red blood cell destruction, leading to hemolytic anemia. Simultaneously, platelets, which are essential for blood clotting, are consumed in the formation of these microthrombi, causing thrombocytopenia, a low platelet count. Because TMA has so many different causes, understanding its true prevalence is challenging. It's considered a relatively rare disease, but specific types of TMA have different incidence rates. For example, Shiga toxin producing E. coli-associated hemolytic uremic syndrome, or STCUS, is more common in children, particularly after a die or heel illness. Thrombotic thrombocytopenic purpura, or TTP, caused by ADMTS13 deficiency, affects both adults and children but is generally more prevalent in adults. Other forms of TMA are linked to specific populations who have received certain medications, undergone transplantation, or have underlying autoimmune conditions. The actual number of cases may be underestimated due to the disease's complexity and varying presentations. The signs and symptoms of TMA can vary depending on the severity and the organs affected. Common symptoms include fatigue, weakness, and pallor due to anemia. Patients may experience bleeding problems, such as bruising or nosebleeds, because of the low platelet count. Neurological symptoms are also frequently observed, ranging from headaches, confusion, and visual disturbances to more severe manifestations like seizures and stroke. Kidney involvement can lead to decreased urine output, swelling, and high blood pressure. In some cases, gastrointestinal symptoms like abdominal pain, nausea, and vomiting can occur. The wide spectrum of symptoms makes early diagnosis challenging. Diagnosing TMA requires a comprehensive approach involving a thorough medical history, physical examination, and a battery of laboratory tests. Key diagnostic findings include evidence of microangiopathic hemolytic anemia, characterized by schistocytes on a peripheral blood smear, elevated lactate dehydrogenase or LDH, reflecting red blood cell destruction, and a decreased hemoglobin level. Thrombocytopenia, or a low platelet count, is another crucial marker. Kidney function is assessed through blood and urine tests, looking for elevated creatinine and blood urea nitrogen, or BN. Importantly, ADMTS13 activity levels are measured to distinguish between TTP, where ADMTS13 is severely deficient, and other forms of TMA. Additional tests may be performed to identify underlying causes, such as Shiga toxin in suspected cases of SUS or autoimmune antibody screening. While all TMA share similar features, they're generally classified based on their underlying cause. One major classification distinguishes between thrombotic thrombocytopenic purpura, or TTP, often caused by ADMTS13 deficiency, and hemolytic uremic syndrome, or HUS. HUS is further divided into STHUS, associated with Shiga toxin producing E. coli infections, and a typical HUS, or AHUS, which is often caused by genetic defects in the complement system, a part of the immune system. Secondary TMAs are those triggered by other conditions, such as medications, autoimmune diseases, pregnancy, or transplantation. Accurate classification is vital as it influences treatment strategies. Treatment for TMA is highly individualized and depends on the underlying cause and severity of the disease. Plasma exchange, or plasmapheresis, is a cornerstone of treatment for TTP, as it removes the antibodies that inhibit MS13 and replaces the deficient enzyme. For STHUS, supportive care, including fluid management and blood transfusions, is often the primary approach, as antibiotics are generally avoided due to the potential release of more Shiga toxin. In atypical AUS, complement inhibitors, such as eculizumab, are used to block the overactivation of the complement system. For secondary TMAs, addressing the underlying cause, such as discontinuing the offending medication or treating the autoimmune disease, is crucial. In severe cases, dialysis may be necessary to support kidney function. Currently, there are no proven methods to completely prevent all forms of TMA. However, certain preventive measures can reduce the risk of specific types. Proper food handling and cooking practices can minimize the risk of SDCUS. Avoiding unnecessary medications known to trigger TMA can also be beneficial. For individuals with known genetic predispositions to atypical HUS, preemptive treatment may be considered in certain situations. Early recognition and prompt treatment of underlying conditions that can lead to secondary TMA are also crucial. The prognosis for TMA varies depending on the type, severity, and promptness of diagnosis and treatment. With timely and appropriate intervention, many patients with TTP and atypical AS can achieve remission. However, TMA can lead to long-term complications, including chronic kidney disease, neurological deficits, and cardiovascular problems. Recent research focuses on developing more targeted therapies for specific subtypes of TMA, such as novel complement inhibitors and ADMT thyroxine replacement therapies. Researchers are also exploring biomarkers to improve early diagnosis and predict prognosis. Ongoing clinical trials are evaluating the efficacy of new treatment strategies and aiming to improve the long-term outcomes for patients with TMA. Thank you for watching.